Hello guys, welcome to the Brains and Needles podcast. In today's podcast, we're going to talk about hyperprolactinemia. So, what is hyperprolactinemia? It is the most common pituitary hormone hypersecretion syndrome in both men and women. The prolactin secreting pituitary adenomas are the most common cause of increased prolactin level. Before we dig deeper into this, let's talk about prolactin, the hormone. What is it? How it is secreted? When the secretion increases? When the secretion decreases? So let's talk about it now. So prolactin is secreted by the anterior pituitary gland. Prolactin is unique among the pituitary hormones in that the predominant central control mechanism is inhibitory, reflecting dopamine-mediated suppression of prolactin release. This regulatory pathway accounts for spontaneous prolactin hypersecretion that occurs after pituitary stalk selection, often a consequence of compression mass lesion at the skull base. So what it means is basically the dopamine D2 receptors takes action in the inhibition of prolactin release. So it basically means that whenever dopamine is active, it will inhibit the secretion of prolactin and vice versa. Now let's get into the normal adult serum prolactin levels. So in a female it ranges from 10 to 25 micrograms per liter, and for male it ranges from 10 to 20 micrograms per liter. So the prolactin secretion is pulsatile, meaning that it has peaks during certain time of the day, like during rapid eye movement, which occurs during sleep. There's maximum secretion, or it reaches the peak, and the level might go up to 30 micrograms per liter, which occurs usually in the early morning, like from 4 a.m. to 6 a.m. So this is a time when the prolactin hormone release will have a peak, which will again get back normal once the person is awake or finishes his or her. Also, if you know that thyrotropin releasing hormone, also a hypothalamic tripeptide, can also cause release of prolactin. Like say after getting a thyrotropin releasing hormone injection intravenously, there might be a slight increase in the prolactin level. Also, vasoactive intestinal peptides can also induce prolactin release. On the contrary, drugs such as glucocorticoids and thyroid hormones weakly suppress the prolactin secretion. Also, we need to remember when the serum prolactin level can rise transiently, like say after exercise, after having meal, after sexual intercourse, a minor surgical procedure, mainly on the chest region, after general anesthesia, a patient suffering from acute myocardial infarction, and other forms of stress can increase prolactin level. Even prolactin level increases significantly during pregnancy, and it decreases rapidly within 2 weeks of parturition. If breastfeeding initiated, the basal prolactin level remains elevated, and also suckling stimulates reflex increase the secretion of prolactin for about 30 to 45 minutes. So yeah, that is also the case. So now when we have the basic idea of the prolactin hormone itself, now let's talk about the disease we're going to talk about, or the syndrome of hyperprolactinemia. So what is the etiology of hyperprolactinemia? There can be physiological hyposecretion in case of pregnancy, lactation, chest wall stimulation, sleep, any kind of stress, or else it can be due to hypothalamic pituitary stalk damage, such as a tumor or a suprasellar pituitary mass, a meningioma, or some kind of metastasis, empty cella, or lymphocytic hypophysitis adenoma with stalk compression, Rathke's cyst, any kind of trauma, or pituitary stalk section suprasellar surgery. Another cause can be due to pituitary hyposecretion, such as a prolactinoma or acromegaly. Some systemic disorders can also cause increased secretion of prolactinemia and further leading to hyperprolactinemia, such as chronic renal failure, hypothyroidism, cirrhosis, epileptic seizures. There can also be drug-induced hyposecretion, such as dopamine receptor blockers, can cause increase in the secretion, such as chlorpromazine, thioxanthines, metoclopramide. Some dopamine synthesis inhibitors, such as alpha-methyl-dopa, some catecholamines depleters, such as aspirin, opiates, some H2 antagonists like cimetidine, ranitidine, some imipramine such as amitriptyline, amoxicillin, calcium channel blockers such as verapamine, certain hormones such as estrogen, anti-androgen, thyroidopin releasing hormone. So, pregnancy and lactation are the important physiological cause of hyperprolactinemia. Sleep-associated hyperprolactinemia reverts to normal within hour of awakening, as I mentioned before. Nipple stimulation or sexual orgasm may also increase prolactin. Chest wall stimulation or trauma can also increase prolactin. Also, some infections with the herpes zoster can invoke prolactin release. Chronic renal failure elevates prolactin release by decreasing peripheral clearance. Primary hypothyroidism is also associated with mild hyperprolactinemia. The lesions of the hypothalamic pituitary region that disturb hypothalamic dopamine synthesis, portal vein delivery, or lactotrope responses are associated with hyperprolactinemia. Thus, hyperprolactin tumors, cysts, infiltrative disorders, and radiation-induced damage cause elevated prolactin levels, usually in the range of 30 to 100 micrograms per liter. Some plurihormonal adenomas, which include growth hormone and ACTH tumors, may directly hypersecrete prolactin. Drug-induced inhibition or disruption of dopaminergic receptors is a common cause of hyperprolactinemia, as mentioned before this, such as some antipsychotic, antidepressive are relatively common cause of mild hyperprolactinemia. Methyl-dopa also inhibits not prolactin, dopamine secretion, and verapamine, which is a calcium channel blockers, blocks dopamine release, thereby causing increase of prolactin. So let's see the presentation and diagnosis. So very classical is the patient presenting with amenorrhea, galactorrhea, and infertility, which are kind of hallmarks of hyperprolactinemia in women. If hyperprolactinemia develops before menarche, the patient will develop primary amenorrhea. But if it develops later, it can go from developing oligomenorrhea and ultimately to amenorrhea. Galactorrhea is present in up to 80% of hyperprolactinemic women. Although usually bilateral and spontaneous, it might be unilateral or only expressed manually. Patient may also complain of decreased libido, weight gain, and mild hirsutism. In men with hyperprolactinemia, there's diminished libido, infertility, or visual loss from optic nerve compression are the usual presenting symptoms. Gonadotropin suppression leads to reduced testosterone and impotence and oligospermia. True galactorrhea is uncommon in men with hyperprolactinemia, although long-standing secondary effects of hypogonadism are evident, including osteopenia, reduced muscle mass, decreased beard growth. So prolactin decreases spermatogenesis in men, and also it has a leucolytic effect, means it decreases the luteal phase. And during pregnancy, to maintain lactation, it decreases sexual drive, decreases steroidization of GnRH, thereby causing infertility or uh, helping prevent pregnancy during lactation. So yeah, it works that way. So galactorrhea is inappropriate discharge of milk containing fluid from the breast. So if it's abnormal, if it's persistent for more than 6 months after childbirth or discontinuation of breastfeeding. So postpartum galactorrhea associated with amenorrhea is self-limiting disorder, usually associated with moderate elevated prolactin level. So like the galactorrhea may occur spontaneously or may be elicited by nipple pressure. In both men and women, galactorrhea may vary in color, so it is also a diagnostic, help where you can have a differential diagnosis and check whether it's breast cancer or no. Also, acromegaly is associated with galactorrhea in about 1/3 of the patient. The treatment of galactorrhea usually involves managing the underlying disorder, that is replacing T4 for hypothyroidism and discontinuation of medicine treating prolactinoma. The medicine related or the drug induced hypersecretion I've already mentioned. So labs. So what you do for laboratory investigation? So you do a fasting morning prolactin level. Normally it should be less than 20 micrograms per liter and should be measured to assess hypersecretion, because hormone secretion is pulsatile and levels may vary widely in some individuals with hyperprolactinemia. It may be necessary to measure levels on several different occasions when clinical suspicion is high. So both there can be sometimes a prolactin level which is like more than 1000 micrograms per liter, which may be falsely lowered because of assay artifacts. Sample dilution is required to measure the high value accuracy. False elevated values may be caused by aggregated forms of circulating prolactin, which are biologically inactive, such as a microprolactinemia. Hypothyroidism should be excluded by measuring the TSH and the T4 levels. So the treatment basically is, firstly you should check whether take a good history before giving the treatment, so you know whether what's the woman's age or the man's age. You'll know about the pregnancy status and various things which will help you to diagnose the disease properly and to treat the patient properly. Whether the patient has some micro or macroadenomas, which is due to which is it happening, is the patient taking some drugs which are causing increase of prolactin. So you have to take that all into account and then go for treatment. The main treatment method is giving dopamine agonist, which will have an inhibitory effect on the prolactin secretion. So there are two drugs which are mainly cabergoline. Cabergoline is a ergoline derivative. It is long-acting dopamine agonist with high D2 receptor affinity. So it is it helps to suppress the prolactin level for about 2 weeks or like say 14 to 15 days after a single oral dose. So cabergoline we usually start with 0.5 to 1 mg twice weekly to achieve normal prolactinemia and resumption of normal gonadal function. Cabergoline helps achieving normal prolactinemia and resumes normal gonadal function. 80% of patients with microadenomas galactorrhea improves or resolves 90% of the patient. Also, it normalizes the prolactin and level and shrinks about 70% of the microprolactinomas. There might be masked effect symptoms including such as headache, visual disturbances improve dramatically within the days after cabergoline initiation. Also, sexual function requires several weeks of treatment but may occur before complete normalization of prolactin level. After initial After initial prolactin level has been achieved, cabergoline should be reduced to the lowest effective maintenance dose. Most of the patients treated with cabergoline um, are do not have a reoccurrence of hyperprolactinemia syndrome. Also, cabergoline might be prescribed to patients who are resistant to bromocriptine, which is our second choice of drug. Bromocriptine is also a dopamine receptor agonist that suppresses prolactin secretion. Because it is short-acting, the drug is preferred when pregnancy is desired. In microadenomas, bromocriptine rapidly lowers serum prolactin level to normal in up to 70% of the patient, decreases tumor size, restores gonadal function. In patients with microadenomas, prolactin levels are also normalized, and there's also tumor mass shrinkage in more than 50% of the patient. The bromocriptine therapy is initiated by administering a low bromocriptine dose, like say 0.625 to 1.25 mg at bedtime with snack, and then followed by increasing the dose thrice a day for 2.5 mg thrice a day. The side effects of dopamine agonists include constipation, stuffiness, dry mouth, nightmares, insomnia, vertigo. Decreasing the dose usually alleviates these problems. Nausea, vomiting, and postural hypotension with faintness may occur in 25% of the patient. These symptoms may persist in some patients in general. Fewer side effects are reported with cabergoline for the approximately 15% of who are intolerant of oral bromocriptine. Cabergoline may be better tolerated intravaginally. Administration of bromocriptine offer effective in patients with intractable gastrointestinal effect. Auditory hallucination, delusion, mood swing have been reported in 5 to 10% of the patient, may be due to dopamine agonist properties or due to lysergic acid derivatives of the. So that's all for today. So hope you understand what is hyperprolactinemia. It was a brief overview of the topic. So we discussed about prolactin, then we dig deeper into hyperprolactinemia. We dig deeper into the labs, diagnosis, the treatment. If you want more such podcasts, please follow us on Instagram, where we have a post about various medical cases and different medical mnemonics and lots more to come. Also follow our Facebook page @Brains and Needles. Follow our YouTube channel Brains and Needles. We are also distributing this podcast to many platforms such as Apple Podcast, Google Podcast, Anchor. Please download the Anchor app where you can also find our podcast. We are also on Radio Public and Pocket Cast and many more podcasts to come. For the podcasting platform, just type Brains, symbol and followed by Needles. So you'll find there. Please subscribe to our channel over the podcasting platforms on YouTube, and please follow us on Instagram and Facebook. Thank you. Have a nice day.